Discussion about thriving survivorship. I'm Courtney Comer. This topic, iron overload, is incredibly personal and meaningful to my family. I am grateful to be joined by Dr. Charles Quinn from Cincinnati Children's Hospital. If you'd like to learn more about Dr. Quinn, please read his biography in the virtual program. Thank you, Dr. Quinn. I am looking forward to your presentation today.
Well, thank you for inviting me. I hope everyone can hear me well. I may be an outsider here in this meeting as a hematologist, or as you may know, in hematology oncology, there's some hyper specialization. But I don't treat patients with cancer directly, at least their cancer. But when I overheard my colleagues talking about iron, and I was like, "Do you guys, that sounds like what I do. Do you guys know what you're doing? Do you need any help here?" And so, because it's something that I deal with every day. And so that's how I came into this clinical situation here. So transfusion-related iron overload. Next slide. And so key points to remember is that you need iron to live. It's necessary for life, but it can kill you if you have too much of it and it hangs around for a long time because it's toxic. So you need it, but you need just the right amount. And if it's too low or too high, that can cause problems. Next slide. And there's a lot of iron in us. Each of us adults on the call have 3 to 4 grams of iron in our body. Most of it's wrapped up or encapsulated in red blood cells as hemoglobin. There it functions to transport oxygen, right? So that's in red blood cells, inside them is something called hemoglobin. That's the oxygen carrying protein. And what actually carries the oxygen and binds to the oxygen on the hemoglobin is the iron. And so that's what all that iron is doing for you, doing there. Now, we have extra iron that we store in case we go through periods of life where maybe our iron intake isn't that high or we're having some bleeding. And after that, it's important to know that there's a small amount of iron in the rest of the body, but most of it is bound up in red cells and the cycle of red blood cell production that I'll show you in just a second. And so as a future point here, if you're getting red blood cells from someone else, that means you're getting a lot of iron, right? Okay, next slide. So this is not to, focus on the intricacies here, but this is just to show you that what comes in our diet every day is about 1 to 2 milligrams of iron, and we lose a little bit of iron every day in normal life. Sloughing of GI mucosa, that's a normal process. You lose a milligram or two, and then if there's any bleeding like menstrual blood loss, you'll lose some there too. So in general, when we're in our steady state, what's coming in the diet is about what's going out, being lost. The iron that does come in, remember, it's toxic, so it's bound to this thing called transferrin right here in the middle, FETF, iron transferrin. Most of it gets cycled around to make red blood cells in the bone marrow. Those red blood cells exit the bone marrow. They circulate for 120 days, then they die. They're engulfed by macrophages, and then that iron is recycled, and most of it goes around in that cycle. And then a little bit of iron is needed by the other tissues, as you can see on the left-hand side of the slide. Next slide. And so 2 points here, not to focus on the intricacies of this cell or this receptor on the top here, but what we have here is on the left side, how much iron gets into your body is entirely controlled by your gut, your duodenum, and there are transport molecules and that sort of thing that help that process. And your body can only increase or decrease iron absorption from the gut. It can take in more or less, but it can't get rid of any extra, right? We just weren't built that way. We can only decrease absorption if we have too much, or increase absorption if we have too little. But if we have way too much, you can decrease absorption, but you still have way too much. You can't get rid of it. And then the other point is, like I mentioned before, iron is toxic. And so you don't have free-floating iron in your body that would damage cells and that sort of thing. So everything is bound to this molecule on the top right called transferrin. So it's like the chaperone, okay? That's the chaperone for iron, transferrin. If you have way too much iron on board and you saturate all your transferrin, then you have this non-transferrin bound iron. That's the thing that causes problems. So too much iron can cause problems because you overwhelm the chaperone. Next slide. And so when we talk about abnormal accumulation of iron in the body, we call that hemochromatosis. That's just the word for it. And that can be a genetic problem, or it could be a secondary problem. If it's not a genetic problem, then how you get iron overload is iron stores increasing by red blood cell transfusions, okay? So get Bill, one slide forward. Yeah, so if you get transfusions, sorry, I have some builds on this that I didn't properly plan for. If you get transfusions, you're getting extra iron. And then if you give transfusions over and over again, you're going to overwhelm or exceed the capacity of transferrin. And then once unbound iron accumulates, all that stuff on the bottom, that's bad things happening in the tissue. You can read it and think about it if you want, if you're scientifically minded, but that extra unbound free iron is toxic and damages the tissues that it's in. All right. So hemochromatosis, iron overload, at some point, unbound iron accumulates, and that's bad for the tissues in which that iron is stored. Next slide. Okay, so why are transfusions the problem then? Two things. One is iron loss is fixed. Remember, you only lose about 1 milligram or 2 a day. That's just the normal, and you can't increase it. And that's stuff that you lose non-specifically from the gut and from menstrual blood loss. All right. So one thing that you'll see is that with women and adolescent girls or anybody who's having menstrual bleeding or any other form of bleeding, that's somewhat protective against the development of hemochromatosis because we don't have a way to excrete iron. But if you're bleeding, obviously we don't want you to have heavy bleeding. That's its own problem. But a normal amount of intermittent menstrual blood loss, well, that can actually be protective. All right, so iron loss is fixed. And then if you go and give a blood transfusion, every milliliter of red blood cells is about 1 milligram of iron. And so if you add it all up, let's say you get about a transfusion once a month, maybe with the chemotherapy cycle, and you do that for a year, that adds up to about 3 to 4 grams of iron, right? And that's what a normal adult individual starts with. A child getting this would start at a lower level and get an adult amount of iron over that time. So red blood cells are full of iron. And then the complications on the right-hand side, it depends on where the iron is stored and how long it's there, okay? And the main storage site or organ for iron in the body is the liver. And so that tends to load first. And then once the liver, so to speak, is full or is markedly iron overloaded, then it tends to accumulate in other organs like the heart and your glands. And so it's pretty straightforward to test for, and that's because that storage form of iron that we have, that's measured or reflected by the serum ferritin, okay? A simple blood test. Now that's great, but other things can influence ferritin too. Having cancer, having inflammation, having infection, that can transiently increase the ferritin. And so really what we'd want to do is to measure directly the iron in the body. And we do that with MRI, magnetic resonance imaging. And that's because you're put in a big magnet and iron in the tissues can affect that MRI signal. And based on that biophysical relationship, we can tell how much iron is in there. And this is great because 20 years ago and before we'd have to do liver biopsy. But now blood test and MRI. And then I'll talk about what the treatment would be. 2 main treatments, phlebotomy, bloodletting chelation, which are medicines, or time. Because remember, if you just have a little bit of iron overload, you're going to be losing a small amount of iron every day. And with time, that might get you back into a reasonable balance. All right, next slide. And this is just to show you the next 3 slides. There's liver and the heart and some organs, just to show you what the iron is doing there. You can actually see it. It's not something, necessarily covert or hidden if you go and look in the tissue. Of course, you can't get a liver biopsy easily, but it's there and you can see it. So this is normal liver. Next slide. And then if there's too much iron in there, for a long enough time, you can get that scarring. And so you can see that circle of lighter tissue around that maybe more normal looking liver there. That's cirrhosis and fibrosis of the liver. And if you look carefully, you can see that little brown stuff. That's the extra iron. Next slide. And if we do a special stain for iron, it turns blue. And so this is somebody with marked iron overload that's been there for a long time, and it leads to fibrosis and liver damage. And everything downstream of that. So liver is very important. And so, okay, here's the next slide. This is also in the pancreas and other endocrine glands like the thyroid or the even gonads, that sort of thing, pituitary. And I don't have the iron stain here, but you can see those little brown globules. That's the hemosiderin. That's the extra iron that shouldn't be there. So you can see it. And if it's there long enough, it can damage that. So if you damage the pancreas, the endocrine part of the pancreas, you get diabetes. If you damage the thyroid from the iron, you get hypothyroidism. And next slide. This just shows you that you can see it in the heart as well. Normal heart on the, heart on the top left, and the lighter areas are the scarred portions of the heart. And then if you stain with the iron stain, you can see it's there in blue. And the heart doesn't like it either. You can have heart failures and dysrhythmias, that sort of thing. All right, next slide. All right, so yes, iron overload is a problem, but you have to take two things into account. One is that it's both the amount of iron and how long it's elevated, right? So if you have a really high level of iron, but you take care of it pretty quickly, it's probably okay. But if you have a high amount of iron that hangs around for a long time, that increases your period of risk, right? And so in general, we want to get those higher levels down sooner rather than later once they're recognized, right? Now, the other thing about organ injury is that in general, what we know most about how extra iron damages tissues is from thalassemia, a different blood disease, and hereditary hemochromatosis, a genetic disease. But for patients that have just transfusion-related iron overload, don't have thalassemia or hereditary hemochromatosis, the risk is probably a little bit lower. It's not gone, but it's not as high as you might expect if you read the thalassemia literature or the hemochromatosis literature. We don't know just how much better it is, but we also know that there's not really a safe amount of extra iron, right? So we want to get it into the reasonable range and look out for the future. All right, next slide. So this is what I mentioned. You can just advance maybe 2 or 3 times, and we can measure iron in the tissues directly by MRI. And we can look in the liver, we can look in the heart, and sometimes there's more in one organ than the other. For example, more liver than the heart. On the right, the liver you see is dark. On the right, you can see that the heart, that circle, that's your ventricle, that's dark too. And so generally, if you just measure one organ, you might miss the other organs. So when you go about looking, you have to keep that in mind too. That you can only see what you shine light on, and so that's you have to consider the patient's history when deciding whether or not to do one or the other or both. All right. Now, in transfusion-related iron overload, like in cancer chemotherapy support, it's usually what we see on the left, where there's more in the liver, less in the heart. We can talk about why if there's a question. Next slide. Okay, so what we did when I started hearing about this, of course, we're not the first people who have noticed this, right? But I just thought this was very interesting because we do this for other transfusion-dependent anemias all the time. And so how do we know who to screen for iron overload? Whom to screen if you're likely or known to have received multiple transfusions. And so, you can go about it 1 or 2 or 3 ways. You can say, well, if you've had more than transfusions, it's probably good to check a ferritin. Or you can say, well, these diagnoses are more likely to get iron overload. And you look at that, they're getting a lot of intensive chemotherapy and getting a lot of transfusion support. But other diagnoses may also, if you're getting lots of transfusion support, may give you transfusion-related iron overload. So You can do it on number of transfusions, or the volume, or as I'll show you, you can just ask to have your ferritin checked, right? And so when do you check that ferritin, which is what I'm showing you on the bottom left? Well, you don't want to check it right away because there's still inflammation in the body that's happening when you're getting cancer chemotherapy and any infection or that sort of thing. So you like to wait, right? 6 to 12 months. And when there's not anything else going on, because inflammation will raise the ferritin and then you'll think it's high from iron, but no, it's just from inflammation. And so generally you get the serum ferritin, pair it with liver function tests because all that iron is in the liver. So we'd want to see if it's causing some early issues. And then screening, we generally don't do MRIs for. Generally, it's based on your ferritin or your LFTs. But some people with abdominal tumors, they're getting MRIs. And then incidentally, they'll see, oh, look, looks like there's iron in the spleen and the bone marrow and the liver. You may see that impression in some of those scans. But you have to do a specific sequence to quantify the iron, right? So you have to talk with the radiologist in advance. All right, next slide. So this is not to go over. This is just to show you, you can read this later if you like, or just think about how we do it, how we approach it. If we're approaching it based on ferritin, generally if the ferritin is less than 200, that's good. We don't need much else. And that's it. On the bottom side, if there's a very high ferritin, that's when we're going to look for how much iron is in the liver by quantitation, right? By measuring it by MRI. And then everything after that is based on what that liver iron content shows, or LIC. It's the in-between ones, right, where they're high, but maybe not high enough to cause problems. We're not sure. And so that's where some serial monitoring and some patient-specific selection and discussion goes into consideration here. If, on the other hand, you're getting abdominal MRIs to monitor a tumor bed or something like that, and they give you an LIC, sure, you can get a ferritin at the same time, but really, if your LIC is less than this number 1,500, and just to be confusing out there, sometimes this is reported as micrograms per gram, 1,500, or milligrams per gram, which is 1.5. So make sure you have the micro or the milli right when you're reading that. So it may sound like 1,500 is a big number, but with micrograms, that's not such a big number. And so it's like before, if it's low, close to normal, the normal adult LIC is about 1,200 or so. It's a little bit different between males and females. But if you're close to that normal range, generally some watchful waiting, if you don't have genetic hemochromatosis, is reasonable. If it's very high, then we got to do something about it. And then in between, just like if you're basing it on ferritin, well, we'll repeat it again and think about other criteria, which I'll talk about in the next slide. All right, so once we think about, you see that the iron level is high enough, or the ferritin is high enough, and the LIC is high enough, the liver iron content, to do something about, well, then we have to think about what can we do or what should we do? And so here's a quick overview. And the overall goal is to reduce the iron stores, your body's iron stores, which we measure in the liver. If we measure it in the liver, we can infer how much is in the whole body, right? So that's why we measure it in the liver. So, and we want to bring that to a normal or near normal amount. And that's because after you give transfusions, stop giving if you don't need transfusions anymore, the iron going in, that big pipe of iron going in, that's no longer giving your body iron. And so based on that slow loss of 1 to 2 milligrams of iron a day, you'll eventually get rid of that extra iron. And that can take many years. If you're still growing, you need extra iron to grow. And so if you're menstrual and if you're growing, that will speed the decline. Then there is another consideration, is that there are people out there who have a genetic tendency to absorb more iron. That's called hereditary hemochromatosis. It's not uncommon. Say, it varies by your geographic ancestry. And so maybe about, 1 to 2% of the non-Hispanic U.S. white population has a hereditary hemochromatosis. So it's not exceedingly common, but you'll pick it up if you'll start looking. And it also occurs in people of other geographic ancestries as well. So that's something to know about. And then if you already have a sick pancreas or a sick liver from whatever happened before, having iron there can worsen that or prevent the healing of that iron. So these are the higher risk features. If high risk, if you're not having periods, if you're male, which means you're not having periods, and your growth is complete, or you have some genetic risk factors for hepatic iron overload, or you have the heart disease, or this other thing called transferrin saturation is high. All right, next slide. And so how we act, other places do it a little bit differently, presumably, but this is how we do it, and we infer it from all of the way we treat anybody with iron overload, right? And so again, it's based on, is your liver iron content low, close to normal, medium, or high? And so if it's high and liver iron content is greater than 5,000, then you're going to need some treatment, likely. And then if it's very high, you might want to take a look in the heart, especially if there's known heart disease in that patient. In between, where a lot of patients fall, is that if you don't have those higher risk features on the other slide, you might get by with just watchful waiting, making sure it comes down and the liver function tests normalize. That would be just fine. But if you have any of those higher risk features, even though you have a medium amount of iron, so to speak, you might benefit from phlebotomy or chelation. And again, if you have heart disease, also look in the heart. All right, next slide. So these are the key decisions in the broad strokes. If you have iron overload, first you have to decide, well, do I just watch and wait? It's a small amount of iron, a medium amount of iron. I don't have those high-risk features. Or if treatment is needed, then you have two decisions. It's phlebotomy or chelation or both. And this is where patient preferences, family preferences, informed decision-making comes into play. And we'll talk a little bit about that. So if you don't need anything, then you just watch. You don't ignore it, but in yearly follow-up, you make sure that LIC is coming down. You make sure that ferritin is coming down. All right. But if you need treatment, then we'll talk about it more on the next slide. Okay, so two ways. Therapeutic phlebotomy. This is bloodletting. And so there's a medieval doctor or whatever they were back then doing bloodletting here. And it's pretty straightforward. If you remove blood, you're removing red blood cells that have a lot of iron. And so you actually throw that blood away or you donate it. And then the body, because you're anemic from that, makes more blood. And to make more blood, it has to use your iron stores. And so your iron stores fall. And then you remove more blood, and the body it goes over and over and over again until you get your goal. So it's pretty straightforward. But when you think about phlebotomy, next slide, you may have the same, when people hear about it, it's like, this sounds a bit intense or brutal. And it's, straightforward in terms of what's going on, but you need an IV and you need to get blood drawn on a regular cycle. And the faster and the more blood you can take off, the quicker the shorter the time will take. All right, next slide. Next slide. Yeah. Okay. If, there is an option then for chelation therapy, this is medications that you can take by mouth, as on the left, deferricyrox, or on the right, this is just so you know, if there's maybe some marked iron overload, there's a sub-Q or an IV form, but almost never use that. The thing with these, though, is they all carry their side effects, and it tends to be liver, renal, toxicity. And so you've just been through chemotherapy. Maybe you've had a kidney removed. Maybe you've had a number of courses of antibiotics, and your kidneys maybe don't need any more irritation or injury. And so generally in that situation, we would err on the side of phlebotomy, even though it may be a bit more technically challenging and people might not like it. All right, next slide. And so when we're considering phlebotomy, chelation, phlebotomy is generally faster, but you need IV access and day hospital appointments. Chelation tends to be slower, but you can do it at home, but it comes with those risks there. Next slide. I'm almost done here. And this just shows you two patients. And these are graphs of serum ferritin, right? So you can see on the patient on the left, very high ferritin, 3,000, something like that. Had serial phlebotomy to bring it right on down. Sounds easy, right? But next slide. That took 27 phlebotomies. And so that's 27 IVs and that sort of thing. And patient two was just modestly iron overloaded, didn't have high risk features. We just waited, and you can see it will come down. I think that was my last slide. This is it. So as a hematologist, I would tell you, like, if you're getting transfusions at the time, you need them. You need them to support, to get you through the process, right? So don't worry about the iron when you're getting them. But the other thing too is that if you're dealing with iron overload, that means you're a survivor. So that's a good thing. And then in that setting, as a survivor with iron overload, we can take care of that extra iron, and then you're done. So very simplistic. And so I think that was my last slide.
Right. Thank you, Dr. Quinn. And so we do have some questions. So would you like for me to read it or?
I will pull it up here. Okay. Upwards of how many blood transfusions? Yeah. So generally, it's about 10 transfusions is a rule of thumb. And so if you like to track volume, that's about 100 milliliters per kilogram of body weight. So each blood transfusion is about 10 per kilo. And so if you get 10, that's 100 per kilo. And
Yeah.
sometimes the blood bank makes that very easy. And you can see, okay, you've had 6,754 mLs of blood.
And so one thing I do want to point out is some families are very good about they will write down and they know exactly how many transfusions, their children have had.
Mhm.
I mean, down to the specific number. One
Yeah.
thing I do want to point out to the audience is that if a child, let's say, for example, having a nephrectomy for a Wilms tumor, at least in my daughter's case, there was what's called a mass transfusion protocol that was initiated, which means she got basically a cooler of blood from the blood bank, which does increase her overall transfusions she's received. And I just want to remind the parents out there that it's okay to ask, how many transfusions did my child receive? It's okay to write it down. And I was going to ask Dr. Quinn, if a parent is concerned and realizes their child has met this threshold or potentially met this threshold and maybe has some features that are concerning, what's the best way to approach their oncologist or their primary care provider and ask for screening?
Yeah, I mean, well, the good thing is that the screening is pretty straightforward, right? You just have to measure a serum ferritin, which is one of the normal iron studies. And so, you know, a chemistry profile and a serum ferritin, you can say, I've been reading about iron overload. I've heard about it in certain forums, and I think my child has had a lot of blood transfusions, may have high iron. So, would you be willing to check for that? The screening is easy. It's just a blood test, right? If that, the PCP or the oncologist doesn't have to necessarily order the MRI that specifically quantifies iron. But, once you have that answer, the ferritin is up or the serum iron profile is abnormal or you have some evidence of hepatic injury, then it's easier, right? You have something to point to for follow-up.
Yes.
Radiology does note iron overload. So this is if you get an MRI and you don't order the sequences to quantify the iron overload, they can't tell you how much is there. They can see that it's there because they will be darker on certain sequences, and you may see, evidence of iron in the liver, the spleen, and the kidneys, and those are typical places where you'd see it. When you see it in the spleen and the kidneys, it's really bound up in the macrophages there, so it's not so much of a problem. And so if there is evidence of iron overload, the radiologist mentioned it, it's worthwhile after you're done with therapy to get that quantified. And people can do that these days. You just have to order the type of MRI that can order that, right? So if you get an MRI of the abdomen, they'll get pictures of the organs and they can see that some are darker, but we want to measure it. And so There's a commercial one called Scan, or sometimes you call it T2 star imaging or R2 star imaging, but a specific quantitation is what you'd ask for.
Okay, so this would be considered an incidental finding that just needs some further investigation.
Right, yeah. Incidental,
Yeah.
but probably not unexpected if you've had a lot of transfusions, right? And I think maybe in the past, um, this was not paid as much attention to. In a sense, with more survivorship, we're seeing more of this. So in a sense, this is a good, it's a good problem to have because you've gone through the hard part, so to speak. I'm not saying that having iron overload is good and getting serial phlebotomy is good, but you've gone through the hardest part, right?
Yes, yes. So I have a question.
Mhm.
So, your slides outline very specific groups for whom iron overload screening matters the most. For example, high risk neuroblastoma, AML, high risk ALL, and a few others. Are these groups identified because of primary diagnosis or because of their treatment exposure?
It's the treatment exposure because they get very intensive chemotherapy with myelosuppression, so they need more transfusion support. So it's a how to frame it for the oncologist to get them used to it. But you can think about these. This one way is to think about the kids that get a lot of therapy because they'll get a lot of transfusions, or you can say, or get a ferritin, or you've had 10 or more transfusions. Those are the three independent overlapping ways to really think about screening.
Yes, and so treatment for Wilms tumor can range from some children may only receive a partial nephrectomy or a nephrectomy to the other end of the spectrum where there are children that are going to receive high dose chemo with stem cell rescue. And so, who really needs to be paying attention to making sure the ferritin is checked after treatment in
Well,
these groups?
yeah, well, there should be a survivorship clinic at your center or somebody that does long-term follow-up and cancer survivor care. And so it should be that person or that clinic. And I think people are increasingly realizing that this is an issue. So this shouldn't be foreign to anybody, I would hope. I'm talking about to the physicians and practitioners out there. Um,
Yeah.
and so it should be. But, if maybe you don't think you're being heard, get your PCP to measure a serum ferritin or something like that, right? And then you'd have some more information.
And that's a really great point because from personal experience, in my case, my child was referred by her liver specialist. So it doesn't have to be, like you're saying, one specific person. It can be another physician that's also caring for the child who may notice it, and it's okay for them to put in the referral or the screening as
Mhm.
well. Um, so I'm sorry.
There's one in the chat, which is if we can't get our kid to get yet another MRI to quantify his blood work sufficient. Well, the problem is that there's a non-linear relationship between ferritin and liver iron. And so what happens when you get iron, when you get transfused, your ferritin goes up and then it will start to peter off or flatten out, even though you're getting more and more and more and more iron. And so for a given individual, a ferritin of 1,000 could be a reasonable amount of iron or a whole lot of iron. And so there is that unfortunate disconnect. But I wouldn't, you don't, if you need an MRI anyway for your tumor bed or that, just add on the sequences. It's not an extra trip to the scanner. And so the frustrating part is that ferritin is okay. It's good for screening, but we can't tell you how much iron is in the body. And so we have some individuals that have a higher LIC with a lower ferritin and the other way around too. So that's what the unfortunate part is. You really have to directly measure the iron to get a good idea of the risk for your child.
Yes. And one thing I did want to point out is that from personal experience, that if there's a biopsy scheduled as a part of surveillance follow-up for any residual tumors, that was another opportunity where my child's providers were able to group in that surveillance, and that was helpful for her treatment plan.
Yeah, if you need a biopsy of the liver, that's great. I
Mhm.
mean, if you need it for another reason, yeah,
Right,
you
right.
don't want.
Yes. Then you can, it's another opportunity to add it on. And a good point that you brought up earlier as well, though, was that ferritin can fluctuate over time due to different factors, and that there is also opportunity to watch it, such as if the child's sick, it could be elevated. And that's
Mhm.
another good point to bring up for people that are concerned about these labs is your point about watching them and taking the whole clinical picture into context. So, Dr. Quinn, thank you so much. I'd like to leave our audience with the line that you ended on. If you're dealing with iron overload, you're a survivor. That reframe is exactly the perspective this session was meant to surface, and we're so grateful for your time. We will now be taking a break. Please join us again at 2 p.m. for our session called What If My Child Relapses?